A very warm welcome to all the participants and all the faculty for today's BLK Telepedes program. This is a bi-monthly program that we conduct conduct from the BLK Hospital Center for Child Health, and we basically aim to discuss about common pediatric topics which are of relevance to general pediatricians in their clinical practice. So today we have come up with another exciting topic, something that we all deal with, but I don't think we ever bother to study about it. So we have some really trained teachers to teach us about orthodontics in pediatrics. Today's speaker is Dr. Priyank Jaina. Dr. Priyank Jaina is currently working as he's the managing director, consultant orthodontist, and cosmetologist at Jaina Dental World. Yeah, so he's the managing director, consultant orthodontist, and cosmetologist at Jaina Dental World, which is a chain of which has two branches, one in Connaught Place and one in GK1. He has received his master's in orthodontics from Davangere and has been practicing orthodontics since then. He also practices in Panipat and Ghaziabad. So today, to chair the session, we have Dr. Neetu Kamra with us, who's a senior consultant in dental and maxillofacial surgeries here at BLKMAX Hospital. And we have Dr. Shikha Mahajan, who is the director in Department of Pediatrics, Centre for Child Health at BLKMAX Hospital. I request Dr. Neetu to please introduce the topic for today and also the speaker.
Yeah.
Over to you, Dr. Neetu.
Very good afternoon to everyone.
Very good afternoon to everyone.
Today's session is about common orthodontic problems in children and how a pediatrician can detect. Since the pediatricians often see the children more regularly than dentists or orthodontists in early life, so they play an important role in early identification and reference. For this, we have Dr. Priyank Jaina, an orthodontist, who will shed some light on these problems. Over to you, Dr. Jaina.
Good afternoon, everyone. Am I audible right now?
Settings screen
sorry, sir. Hello. Hello.
You can correct.
Hello.
Video की setting है.
Settings. Is the slide visible, sir?
Okay बटन होगा नीचे क्लिक करो.
So 1 second. I'll just take a second to figure it out. Is the slide visible right now, sir?
Yes, your slides are visible, Dr. Jaina.
All right. Thank you. Good afternoon, everyone. Am I audible right now? And is the slide visible?
Yes, you're good to go.
Thank you. Thank you. So good afternoon, everyone. And thank you for inviting me to this wonderful CME session right after the lunch. I'm sure everyone must be a little sleepy, but I'll try to make it a little interesting. It's great to be back at BLKMAX Super Specialty Hospital. And thank you to the respected chairpersons, Dr. Karna and Dr. Mahajan, for the kind introduction. I am grateful to Dr. Ankit, who has been my dear friend, support, and my schoolmate, and who has given me the honor to speak in front of all of you. Today's talk focuses on common orthodontic problems in children, what a pediatrician should know. Orthodontist is no longer just about straightening teeth. Malocclusion is closely linked to the airway health, facial growth, speech, sleep, nutrition, and psychosocial development. As pediatricians, you are often the first to observe children throughout their growth years, placing you in a crucial position to detect early craniofacial abnormalities. Early recognition allows a simpler, less invasive, and more stable treatment during growth. The aim of my talk would be to identify the key findings early and understand them timely so that referral can significantly benefit the child. This is the basic content of my talk. I'll just get on with it. The pediatrician role in orthodontics. Most children visit pediatrician much more frequently than the dentist during their early years. Routine wellness examinations provide a tremendous opportunity to observe facial symmetry, breathing pattern, oral posture, speech, and dental eruption. One major concept is the relationship between the maxillary construction and the airway function. A narrow maxilla often leads to increased nasal airway resistance. These children frequently become mouth breathers. Chronic mouth breathing is not a harmless habit. It alters the tongue posture. Normally, the tongue rests against the palate and it acts as a natural expander for the upper jaw. In mouth breathing, the tongue drops down. As the tongue drops down, it removes the stimulus and the palate becomes narrower and deeper. This creates a vicious cycle in which we have a narrow maxilla, nasal obstruction, mouth worsening, maxillary construction. Pediatric obstructive sleep is strongly associated with craniofacial morphology. May present with daytime fatigue, irritability, concentration, and symptoms mimicking ADHD. Speech is another area. Certain malocclusion produces characteristic articulation problems. The anterior open bite often causes a of S and Z sounds. Class 3, in which basically the lower jaw is a little too prominent, a problem in F and V sounds. Mastication and nutrition. Coming to the mastication and nutrition, the masticatory efficiency is also affected because of nutrition, and the child might avoid hard food and have all. Finally, never underestimate the psychosocial impact. First, children with dental irregularities have more vulnerable to teasing, bullying. They usually have a low self-esteem. Therefore, orthodontic issues should be viewed as functional concerns, not purely cosmetic. Now we need to understand the normal dental development in a mixed dentition. Before we can identify any abnormal. The mixed dentition phase. This is a critical window between the age of 6 and 12. During this period, both primary and permanent teeth are present simultaneously. This is a dynamic stage with rapid changes. Many parents become anxious when they see or irregular eruptions. It is important as pediatricians to know which findings are physiological and which are not. One concept is incisal. That is, the permanent incisors are significantly larger than the primary ones. This is both good and bad. Good in the way that many times in children we observe spaces between the teeth. As the permanent one, those spaces close down by themselves. At the same time, in case a child has all the deciduous in a line without any space, the permanent will invariably come out as crowded. Fortunately, as the child develops, as the jaw develops, the dentition has some compensatory mechanisms also. One is the physiologic spaces that I just spoke about. Second is, as the child grows, the intercanine width also increases. As the intercanine width increases, we get space for the teeth to line. Then, as the jaw grows, there's more growth towards the back, so we get more space for the back teeth to erupt. And concept is deviate space. That is the size between the erupting permanent, the deciduous molars and the erupting permanent premolars. A 1.5 mm space in the and 2 in the lower, which is very crucial for the natural. Now we come to the ugly duckling stage, a physiological self-correcting stage usually seen at the age of 8 to 10. But usually develop in this stage, which as the canine erupting down, as the canine comes down, the lateral and the center each other, hence space. This we usually observe as there's a big space between them. Many parents, they usually come to us during ugly duckling stage for treatment. But as a pediatrician, understanding normal developmental patterns help you to reassure the parents appropriately while you are able to identify any deviation from the natural is actually happening. We'll come to the crowding space eruption. One of the most orthodontic problems seen in children. It occurs when there is insufficient arch length to accommodate the erupting permanent. Mild crowding may self-correct. Crowding often worsens with time. Crowds are hard to heal and increases plaque accumulation, and hence children have higher risk of dental caries, gingivitis, and even gums problem. The structure periodontal problem. Second, come to the space. It sometimes can also indicate an underlying pathology. Midline diastema, large millimeters, persisting after canine eruption requires an investigation. It might be because of mesodents or because of labial going from the upper to incisors, because of the space opens up over here. Or it can be even because of any pathology like cyst. Now come to the primary. It is very important to us clinically as the primary molar can be lost because of early caries. As the permanent molar starts drifting forward into the space, decreasing space for the permanent erupt from below. There's loss of molar because of a deciduous tooth away. The permanent molar is drifting forward, and when the try to erupt, the space will decrease. In such cases, a space maintenance eruption anomalies deserve special attention, like ectopic eruptions, teeth, or ankylosing. So over here, the canines which are impacted, no space for them to erupt into the mouth. In such cases, do extraction permanent tooth, and with braces, we pull the canines down. Coming to those teeth are usually submerged below the adjacent, fused directly to the bone, and they fail to erupt normally. And unexplained eruption asymmetry or delayed eruption should prompt radiographic evaluation and referral. Now, I would like to start with the 3 planes problem can happen. The transverse plane, in which we can have an anterior or a posterior crossbite. Ideally, the upper teeth should envelop the lower teeth. But in case the upper teeth bite inside the lower teeth, it is known as a crossbite. It can be posterior, unilateral or bilateral, dental or skeletal. Skeletal cause pressure. because suppose the upper teeth are too far palatal placed over here, and the child will try to move the J problem, excess binding of the teeth. It can even cause symmetry in long runs, and it can cause hypertrophy on one side. Early treatment is important because maxillary expansion is highly effective during childhood when the suture is not. Pediatrician should suspect transverse deficiency in children with mouth breathing, narrow V-shaped palate, any functional jaw shift. This is a case of a frostbite of the molar. We started early. All our teeth had not even erupted yet. For a night eye, we will expand the jaw, make space for the remaining teeth to fit in. Coming to the second plane, that is the vertical. It can be open by it can be ideally the upper anterior teeth should overlap the lower by 20 to 30%. That is around 2 to 4 millimeters. Vertical discrepancies involve abnormal overlap between upper and the lower teeth. Am I going? Vertical discrepancy involve abnormal overlap between the upper and lower teeth. Anterior open bite occurs when the front teeth fail to overlap and is commonly caused by thumb sucking, prolonged pacifier use, tongue thrust, or airway obstruction. Normal tongue posture inhibits the eruption of the anterior teeth, affecting the speech. It can also affect the child might not be able to bite comfortably from his or her front teeth. It can cause aesthetic problem, and obviously it sometimes causes lisping. A deep bite, on the other hand, is an excessive overlap upper and the lower teeth. Severe cases may traumatize the palate and restrict mandibular growth. It can be caused due to over-eruption of the incisor, under-eruption of the. It can be a combination of both, and it can be because of a asymmetrical skeletal growth pattern. In bite, the pediatrician should always evaluate the oral habits, airway issues, and then advise treatment by a orthodontist. This is a case for overbite, in which the overlap is almost 60%, in certain areas, the incisor over here. With braces, we were able to check, and he had perfect overbite by them. In the case of an open bite situation, braces later overbite. He could not even bite this teeth, and he was so happy. His chewing, even having corn, was comfortable for him by the end of it. Now, coming to the third plane, that is the sagittal plane, in which we have class 2 and class 3 malocclusions. Basically, the front to the back relationship of the jaws. In case of the upper jaw is or lower jaw protrusive. This combination of upper jaw and protrusive. A patient usually have a convex profile in this. This is very important medically because many of us see with convex profile and the side very prone. Sometimes a child to pattern of being too comes to us with fractured teeth. From regular, we address problem during the growth, peak pubertal growth. So between 10 to 13, we wish to check so that we can actually grow the jaw, help in the growth of the class 3 or underbite. Lower jaw is prominent, the upper one. In this, early orthopedic can have the growth of a jaw. This treatment is done as early as the age of 7 to 9 years of age, when the sutures might be completely fused. So this he did not come at the right time. He had to undergo surgery. Recognition would have, we might be able to in front using. This is a child, a class 2 pattern, upper incisor being clear. You see a lip top, upper incisor very, very prominent. Luckily, he did not. There was over here. We were shocked. The straight teeth here. The line improved as soon as you were able to job, also suddenly improved. This is a patient class 3. She had a look of at least a 10-year older child because her were not visible when she used to smile. And there was a very deep bite. So there was a collapse in the bite actually over here. That's why we can see lower lip is actually out. You have to push your teeth out, the upper teeth out. And coming to the airway and sleep connection. So pediatric OSA. Modern orthodontics recognizes the connection between airway health and craniofacial development. Pediatric obstructive sleep apnea differs from adult obstructive sleep apnea. In children, the craniofacial anatomy often plays a major role. Adenotonsillar hypertrophy commonly initiates this process. Obstruction becomes, as we explained before, as the mouth, the tongue posture drops. As the tongue drops, there's no resistance to the maxilla, so the maxilla also collapses and it becomes narrow. We see the characteristic features, adenoid facies, in which we have a long face, a narrow long face, constructed maxilla, open bite, retrognathic mandible, and systemic. In case of OSA, we many times see even some systemic manifestation like snoring, restless sleep, daytime hyperactivity, poor academic performance. Importantly, these children are sometimes mislabeled as behavior disorder when underlying issue is actually sleep fragmentation. Because the child is not sleeping well, that's why the child is actually showing all these signs. In case of obstructive sleep apnea, the management requires multidisciplinary care of a pediatrician, a orthodontist, and a sleep physician. The orthodontist would give a rapid expansion, expand the jaw, and sometimes even lower jaw in front. The jaw moves, the area at the back opens up. We usually advise a consultation with ENT before any orthodontist. Coming to the oral habits and myofunctional issues. First is the nutritive sucking. It is extremely common in children. Sucking and passive use are considered normal in infancy and early toddler years. Usually the age we want the child to stop any pacifier or bottle feeding or even thumb sucking. In case of a non-nutritive sucking, depending on its frequency, duration, and the intensity, we can see the effects on the jaws and the teeth. A persistent thumb sucking commonly causes a narrow upper jaw, a posterior crossbite because of the narrow upper jaw, anterior open bite because that's the place where the thumb or the pacifier is going repeatedly. The upper incisors being proclined because they're being pushed out by the thumb. The lower incisors being retroclined, that is, they are pushed back again because that's where the base of the thumb rests. tongue thrust is another major factor. And during swallowing, the tongue pushes against the anterior teeth instead of the palate, which again can cause an open bite. Sometimes just finding out why the open bite has happened, whether it is because of persistent thumb sucking or now is it because of the tongue thrust, gets a little difficult. This abnormal muscular pattern perpetuates an open bite even after the suckling habit stops. In this, the management is mainly first positive reinforcement. We tell the child to stop thumb sucking as far as possible. We take the picture, show it to them that this is a wrong habit. We give them rewards. We sometimes even ask the parents to put a medicine known as no bite, which is a very sour medicine. We ask them to put it on the thumbnail so that if the thumb goes in the mouth, the child removes it. But none of the treatment is effective till the child actually wants to leave it. As far as possible, a punishment should be avoided. In case all these basic treatment modalities don't help of positive reinforcement, rewards, photographs, no bite, then an orthodontic appliance known as a habit-breaking appliance, which goes on the palate and it forms a crib on the palate, with preventing any thumb from going in, is advised. The pediatrician plays an important role because parents often discuss these habits with them, and then the pediatrician can send the child to an orthodontist. These are some craniofacial and syndromic considerations where, again, an orthodontist treatment is necessary. Things like Cruzen syndrome with midface deficiency, shallow orbits. We usually see a severe crossbite in such cases. A Perio-Robbins sequence in which, again, there's a micrognathia, the tongue is really large, airway is compromised, and sometimes we see cleft lip also with this, cleft lip and palate with this. Treacher Collins, also known as bird face, in which the lower jaw is really small. There's usually a ear defect. The face is a little asymmetrical, and again with a cleft, sometimes with a cleft. And last is the cleft lip palate, which usually associates with missing teeth. The upper arch is collapsed. There is a crossbite and severe crowding. In any of these situations, we need a multidisciplinary approach between the pediatrician, the orthodontist, the surgeon, and sometimes even the prosthodontist for repair and replacements. This is a case of a cleft lip palate patient. We started her treatment early. I think around the age of 9, we started her treatment. We first gave her a face mask and we were able to push the upper jaw out. Along with the face mask, she had an expander to expand the upper jaw too. By the end, we were able to get a good profile. We had to replace 2 teeth because they were rotten. Because of the crowding, she wasn't able to brush well. And 1 incisor was missing also for her, the lateral incisor. So we had to use the help of a prosthodontist. So we had to replace the teeth, and she had a decently good bite by the end of it. She also needed a surgery in between as we expanded the jaw. The cleft area had no bone in it, so she had to go for a bone graft over there. Coming to the interceptive orthodontics, the modalities and timings. It is usually done during the age of 7 to 10 years of age. The goal is not comprehensive braces treatment. Instead, it is to guide the growth and prevent worsening of the problem. Usually, if we do an interceptive orthodontic, then later on, if braces are needed, the treatment is of a much lesser time. In this, the key objectives are to expand the constricted arches and hence correct the crossbites, preserve the space. As I mentioned, in case the deciduous teeth fall early, the permanent teeth try to drift into that space. So we give a space maintainer to maintain the space over here. We guide the jaw growth. So there's a twin block given over here so as to push the lower jaw in front whenever the child bites, hence enhancing the growth of the lower jaw. In all this, the timing is very critical. Most of the orthopedic interventions are effective only during the growth. Like the expander works best when the sutures are not fused together. So by the age of 10, 11, the sutures get fused, then it is very difficult for us to open them. Functional appliances are also best used during the peak growth spurt. So between 10 to 30, we use the functional growth. Early intervention can reduce the treatment complexity. It can avoid extractions, reduce trauma risk, improve the airway dimension, and decrease likelihood of surgery later. At the same time, not every child needs a orthodontic treatment. Proper case selection is essential. My advice is, in case you see a crossbite, or early loss of tooth, or a small jaw, the child should be referred to an orthodontist immediately. This is a clinical case. She came to us at the age of 12 she has a habit of mouth breathing. The palate was very narrow, and there was a crossbite bilateral. We gave her rapid maxillary expansion, which was done over the period of 6 months. At the end, we could see almost 3 to 4 millimeter space between the incisors, because that's much how we were able to expand the jaw. We were able to correct the crossbite, improve the arch width, increase the nasal flow, and even improve her nasal breathing. If you see the beginning picture, we can see how sleepy she's looking, this dullness in her face. But by the end, she was nice and bright. She was very happy with the results. She was
पूजा इसको देख लेना, अगर सही है तो खाना, नहीं तो चिड़िया को डाल देना। जरूरी नहीं है कि खानी है, पुरानी अगर सही होगी तो खाना, नहीं तो फेंक देना, चिड़िया उड़िया को डाल दियो। क्या बेटा?
we could see actually the happiness in her face, the brightness in her face by the end of the treatment. Her parents always used to initially complain of snoring. By the end, her snoring had absolutely gone. This slide is perhaps most clinical practical for a pediatrician. The American Association of Orthodontists mandates that the orthodontic evaluation should be done by the age of 7. This does not mean every child needs braces at 7. Rather, it just allows early identification of developing skeletal and dental issues. Key referral indicators are premature or delayed loss of primary teeth, difficulty in chewing, biting, or visible functional shift, chronic mouth breathing, snoring, or any sleep disordered breathing, thumb sucking pacifiers after the age of 4, proclined incisors because they are high risk of trauma, any anterior or posterior crossbite. Functional shifts are especially important because they may influence jaw growth. Crossbites almost never are self-correcting. They are actually considered as orthodontic emergencies. The day we see a crossbite of permanent tooth, we need to correct it because it causes jaw disturbances, and later on it is very difficult to correct. Children with increased overjet are high risk of dental trauma. So any early identification allows growth modification, whereas the late treatment, in case we don't expand the jaw on time or we don't grow the jaw in time, then it can actually require a surgery. Successful management of orthodontic problem in children requires a teamwork. It is a team between the pediatrician, ENT specialist, speech or the myofunctions therapist, orthodontist, and the pediatric dentistry. A pediatrician role is the primary gatekeeper. He or she is the one who's sending the child to the various doctors. They need to monitor the growth, identify airway issues, screen the habits, and coordinate the referrals. ENT specializes in managing the adenotonsillar hypertrophy and any nasal obstructions. The speech and myofunction therapist addresses abnormal swallowing patterns, the tongue posture, and any speech distortion, which can be because of an open bite or a deep bite or a small jaw or even a tongue thrust. Orthodontist guides the jaw growth. He or she would correct the malocclusions and preserve the space. A pediatric dentist helps to manage the caries and maintain the oral health. No single specialty can fulfill all the problems independently. When multidisciplinary collaboration occurs early, outcomes are significantly better, both functionally and psychosocially. Ultimately, our common goal is healthy craniofacial development and improve the quality of the life of the child. To conclude, orthodontic problems in children are not merely cosmetic concern. They intersect the airway health, sleep, speech, mastication, growth, and psychosocial well-being. Pediatricians are uniquely positioned to identify early abnormalities because of repeated longitudinal contact with the child during active growth. Remember these key take-home, which are there in all these questions. Any mouth breathing is never normal. Crossbite rarely self-correct. Persistent oral habits influence the jaw development. Increased overjet increases trauma risk. Early intervention can modify growth and reduce future treatment burden. So the rule of thumb is if something about the child's bite, breathing, jaw growth, or facial development appears abnormal, or orthodontic evaluation is beneficial. A timely referral at the right age can completely change the long-term prognosis and the treatment plan for the child. Thank you. These are my contact details. Any questions? I'm open to take the questions right now, or you can mail me or call me later also, please. Thank you.
Thank you, Dr. Priyank. It was a very detailed presentation, and as pediatricians, I do not know how much we have understood, but we have definitely understood the importance of getting a dental treatment as early as possible. Okay, and
Thank you, Dr. Karma.
as a regular visitor to my dentist, I know how important it is to maintain your teeth and to start it as early as possible. I remember one of my senior dentists used to always tell me that, Dr. Shikha, you must come for a 6-monthly checkup even if you don't have any problem. And I never went. But I think that is what is most important. And we do not realize the importance, the pain, the stress. It's not only the looks, it is your teeth define most of your things, your temporomandibular joint, the stress there. So I think as pediatricians, we must not overlook any problem related to teeth. And an early referral and an early intervention probably is the key of managing all the problems, because these are going to be with us till our old age. Teeth is one structure which is going to be with us till the time we die. So it should be given its due importance, and we must address the issues as early as possible. And an early referral to a dentist is very, very important. So any questions if we have, we can definitely take. If you don't have any questions, we can conclude the session. And thank you, Dr. Priyank, for a very elaborate presentation. The emphasis was very, very important. Thanks. Thank you, Dr. Neetu, for being with us. So, Dr. Ritika, we conclude. Dr. Ritika? I think with this, we conclude. Thank you, Dr. Priyank, for joining us. Thank you. You're able to hear me?